Namaskar, dear viewers. Welcome to today's session. And we are heading towards our 300th webinar. So, I really thank all of you for your participation, for your encouragement, and for your support, and for all your nice comments and positive comments, and continuing your well wishes. So soon we'll be forming a society also, and we shall taking this forward. Our channel will now go and into formation of a society, and it'll probably be called Society India Intensivist. And we shall create a website which will be a very vibrant website, multifaceted in terms of educational resources, and there'll be many other things, right? So I'll let you know the details in the coming time, and I encourage all of you to join as members of our society, which will be an India-based society. And of course, anybody can join. People from abroad are also welcome to join it. So I'll let you know the details soon, and do join the society as soon as possible. Thank you very much. So today's session is on oxygen, right? And oxygen is a key molecule and very, very important. Life depends on oxygen, and the cardiovascular system and the pulmonary system, the basic function of this is to give oxygen to the tissues. So oxygen is the endpoint for the pulmonary as well as the cardiovascular system. That is how important it is. So we are going to be educated by Dr. Vetriselvan, who's done his DM in critical care medicine from the prestigious All India Institute of Medical Sciences, and he's a critical care consultant at Kavadi Hospital, Chennai. He's also a member of the ISCCM branch of Chennai. So with that, I hand it over to you, Dr. Vetriselvan.
Thank you, sir. First, there is a two common reasons patient come to ICU. There's a one reason is a hemodynamic support. The second reason is a respiratory support. Whenever you are supporting a respiratory system, we always most of the patient will supplement oxygen also. So it is oxygen supplementation is the most common intervention in critically ill patients. Like any drug, like any intervention in ICU, that any underdosing will harm the patient, overdosing also will harm the patient. Like oxygen also have a lot of biochemical and physiological options. In underdosing of oxygen, it is hypoxia can harm the patient. Overdosing of oxygen like hyperoxemia can harm the patients. So we're going to see about why oxygen is needed, what is the optimal dose of oxygen, what are the effect of hypoxia and hyperoxemia, what is the recommended, what is the optimal dose of oxygen in our patient admitted in critically. Okay. First, when you see here, what is oxygen? Oxygen is a colorless, odorless gas essential for the aerobic metabolism. In a normal atmospheric concentration is 21%. When you inhale this atmospheric air, it goes to the lung, it crosses the alveolar membrane, it reaches the blood and reaches the tissues. Okay. So normally there is a what is the role of oxygen at the tissue level? Why we need a oxygen at the tissue level? Okay. So normally our functions, all our cellular metabolism depends upon oxygen. So something is called oxidative phosphorylation. The normal aerobic metabolism is depends upon the oxygen at the tissue level. So when our patient have the adequate oxygen at the tissue level, this aerobic metabolism will produce 36 to 38 ATPs. When you don't have the adequate oxygen at the tissue level, it produces the anaerobic metabolism. It only yields 2 ATP and also it produces the lactate. Okay. So these anaerobic metabolisms are harmful. Whenever you have the adequate oxygen at the tissue level, that the tissue will go for the anaerobic metabolism. It produces only the minimal ATPs. Second thing, it will produce the lactate. Production of lactate will cause lactic acidosis. Little ATP will go for the energy failure. The both acidosis and the energy failure will leads to the cellular and organ dysfunction. These reasons that always all cells need continuous adequate oxygen supply at the tissue level. Okay. So whenever you inhale the oxygen, normal atmospheric pressure is 760 millimeter mercury. At the atmospheric air, the oxygen constant, oxygen PO2 will be 160 millimeter mercury. When the because of the humidity in the tracheal level will be 150, and because of the alveolar CO2, the alveolar level is going to be 100 millimeter mercury. If the oxygen, the PO2 level, it will continuously it decreases in the arterial blood and capillary and intracellular. At the mitochondrial level, you will see that at least it's minimal oxygen requirement at the mitochondrial. It's 1 to 5 millimeter mercury. Okay. So what are the factors determine the oxygen delivery to the tissues? I already told that all cells need continuous adequate oxygen at the tissue level. So what are the factors determine the adequate oxygen delivery to the tissues? One is the hemoglobin. Second is the dissolved oxygen. Okay, all our inhaled oxygen, it goes to the alveoli and it reaches the blood. It bind with some of the oxygen bind with hemoglobin. Some of the oxygen will be dissolved in the oxygen. So if you apply this routine formula, you know that 1.39 into hemogram in saturation plus 0.003, it is a solubility of oxygen in the liquid and the PaO2. If you apply 15 hemogram with saturation of 100, it will comes at the total oxygen. It is 20.585 from the hemogram binded oxygen. 0.3 will come from the PaO2. Okay, if your PaO2 is 100. If you see here, the predominant oxygen content is determined by the two things. One is the hemoglobin concentration. Second is the our saturation. It's not like PO2. See, the PO2 is contributing in that the PO2 is 100. The PO2 is contributing the oxygen content is 0.3 only. Okay. So the total oxygen content in the blood is 21.15 ml per deciliter. The second thing is that oxygen delivery to the tissues, not only it depends upon the oxygen content, it also depends upon the cardiac output. We see here what are the factors determine the oxygen delivery to the tissues. It's the saturation, your binding of hemoglobin level, and your PO2 it's minimally contributing. Third is the cardiac output. Okay, is there any problem in this cardiac output or hemoglobin concentration or saturation level, or it is a PO2? All can cause the inadequate oxygen delivery to the tissues. Okay, so if it is the inadequate oxygen delivery to the tissues or inadequate oxygen utilization at the tissue, it is called hypoxia. If you the practical bedside definition of hypoxia is a state where oxygen delivery is insufficient for the metabolic need of the tissues. Okay, or the tissues are unable to utilize the available oxygen effectively, it is called hypoxia. Okay, so a lot of people are used to be confused between hypoxia, hypoxemia, and dysoxia. Hypoxia means there is a tissue at the level of tissue level, there is a less oxygen is available or unable to use the oxygen, it is called hypoxia. Hypoxemia means there is a abnormally low partial pressure of oxygen in the arterial blood. Okay. So if example normal, the PO2 will be in the 80 to 100. If anything is less than 80 a PO2 in the blood, it is called hypoxemia. Some of the hypoxemias may be asymptomatic. Example 60 to 80, it may be asymptomatic. Sometimes you will keep a PO2 of 40 to 16 ARDS patient and sometimes in the CO3. So that hypoxia is different, hypoxemia is different. Why it is different, I will tell you later. The third one is a dysoxia. Dysoxia means it's a subset of hypoxia. It is oxygen is available at the tissue level, but because of the impaired cellular respiration, the tissues cannot use the oxygen, inability to use the oxygen, most commonly associated with mitochondrial dysfunction. Hypoxia means there is a at the level, at the tissue level, less oxygen is available or unable to use oxygen, it's called hypoxia. Hypoxemia means there is a PO2 level is low in the blood, it is called hypoxemia. The dysoxia means adequate oxygens are there at the tissue level. There is no problem with the lung, there is no problem with circulation, there is no problem with saturation. The tissue, the blood is delivered the oxygen to the tissue level, but the tissues unable to use oxygen, it is called dysoxia. So what are the common causes? We know about the hypoxia, common cause of hypoxia and hypoxemia. What is the common causes of dysoxia and the critically ill patients? One is a sepsis. This sepsis will cause mitochondrial dysfunction. So the mitochondrial dysfunction, they cannot go for the oxidative phosphorylation. So even the adequate oxygen at the tissue level, they cannot use. Second thing is the cyanide poisoning. It inhibits the cytochrome C oxidase. Third is hydrogen sulfide toxicity. It's very rare. The fourth common is a tissue reperfusion injury. They produce a lot of free radicals. It damage your mitochondria. Is any acidosis, not severe lactic acidosis, any severe acidosis can cause mitochondrial dysfunction. So whatever the causes, sepsis, cyanide poisoning, reperfusion injury, severe acidosis, all will cause mitochondrial dysfunction. If the mitochondrial dysfunction is they cannot use oxygen at the tissue level, can cause dysoxia. Okay. So just remember that hypoxia means there is low oxygen in the pipeline. There is low oxygen in the arterial bed. Hypoxia means there is low oxygen reaching or used by your house. It is called hypoxia. Dysoxia means the oxygen is reached your house. The house cannot use it. That is a mitochondrial dysfunction. It's called dysoxia. Okay. So when you, how will you differentiate all these things at the bedside? The definition we already discussed. The hypoxemia means there is a low PO2 in the blood. Hypoxia means less oxygen availability or in unable to use oxygen at the tissue level is hypoxia. The dysoxia means inability of oxygen, inability to use the oxygen, but oxygen level at the tissue level is normal. Okay, it is called dysoxia. How can you measure these things? Hypoxemia you can easily measure by our PO2. If you took the ABG, the PO2 level is lower than the normal range, we can call it as hypoxemia. Hypoxia mostly by the clinical signs or with the surrogative markers. For example, if hypoxia is severe, it can go for anaerobic metabolism. This anaerobic metabolism will produce a lactate. The dysoxia always associated with the lactate because there is oxygen is cannot the inability to use oxygen. Obviously, the mitochondria will go for anaerobic metabolism. The anaerobic metabolism will produce a lactate, so lactic acidosis. The dysoxia always associated with elevated lactate. The saturation is similar. That is SpO2 usually low in the hypoxemia. Hypoxia, it low, but sometimes it is normal. I will explain later. Sometimes even the patient having normal saturation in the blood, the inability to use the oxygen and in those conditions, the saturation can be normal in hypoxic condition. The dysoxia, mostly the delivery, there is no problem with the delivery of oxygen to the tissue. So always the dysoxia situation, the SpO2 will be normal. The PO2 also like that only. PO2 will be hypoxemia will be low. Hypoxemia may be normal or high, or it may be low. In the dysoxia, always normal or high. Okay. Fifth one is the oxygen delivery to the tissues. In hypoxemia, normally the blood oxygen concentration, the PO2 is low. Normally, whenever that low PO2, the body will do some compensatory mechanism. For example, the patient will trying to increase the cardiac output to maintain a normal oxygen delivery to the tissues. Okay, that reasons oxygen delivery may be normal or low. Okay. The second thing is a hypoxemia. Hypoxemia, always the oxygen delivery will be low, especially in a shock and anemia. The three one is the dysoxia, the oxygen delivery will be normal. Okay. Oxygen utilization, if you see here, it is a normal in hypoxemic patient, hypoxemia patient. In hypoxic patient, the oxygen delivery will be low. So utilization also will be low. Dysoxia, the oxygen, there is a problem with the oxygen utilization, so they're severely impaired at the tissue level. If you see hypoxemia commonly caused by our lung problems, ARDS, pneumonia, or pulmonary embolism, there is a gas exchange problem. So the oxygen won't reach the blood, so it can cause hypoxemia. Hypoxia most commonly lung also can cause hypoxia, but additionally, your anemia, the shock, low cardiac output, or carbon monoxide poisonings are other common causes of hypoxemia. The dysoxia, most likely, it's related to, we already discussed, is a mitochondrial dysfunction, sepsis, cyanide poisoning, or other reasons for a mitochondrial dysfunction. The lactate already told, not most of the hypoxias, severe hypoxia will have the high lactate, but dysoxia always will have the high lactate. Okay. Why it is important? Okay. So why it is important? Why we have all these definition? You have to separate hypoxia, hypoxemia, and dysoxia. Patient can have hypoxemia without hypoxia. That is, that patient may have the low oxygen in the blood, low PO2 in the blood, but at the tissue level, oxygen delivery may be normal. So hypoxemia, patient can have hypoxemia without hypoxia. For example, if the low PO2, what normally high altitude situation, there is a compensatory mechanism will be the arterial the PO2 may be low. The compensatory mechanism will be they increase their cardiac output, they increase the hemoglobin. So the these compensatory mechanism ensure that adequate oxygen delivery to the tissue level. It's more common in the high altitude situation. So hypoxemia can occur without hypoxia. The second thing is that you can have hypoxia without hypoxemia also. For example, the blood oxygen level, PO2 level, and saturation level, everything is normal, but the tissue level, the patient cannot use oxygen like dysoxia. So patient can have hypoxia without hypoxemia. So this reason there is a different definition for hypoxia, hypoxemia, and dysoxia. One reason. Second thing, there is a other important reason, prognostication. For example, all this hypoxia and hypoxemia we can correct. You can supplement the oxygen. We can put a ventilator. You can even go for extracorporeal therapies. VVECMO, all will help us to ensure we can correct our hypoxia and some form of the hypoxia. As a hypoxemia, some form of hypoxia. But dysoxia, it's very, you see here, that is a mitochondrial dysfunction. even if put on ventilator, even if put on extracorporeal support, it cannot, it's very difficult to correct the dysoxia. You have to treat the primary cause, you have to treat the sepsis. If sepsis improves, mitochondrial dysfunction will improve. If it is cyanide poisoning, you have to treat the cyanide poisoning. Those supportive therapies won't benefit in the dysoxia. So dysoxia patient used to have, compared to the other hypoxia and hypoxia, the subset some as a hypoxemia, this dysoxia patient used to have the worst prognosis in the critically ill patients. Okay. So what are the clinical clues to suspect hypoxia? Whenever that oxygen delivery to the tissues is low or oxygen utilization is inadequate at the tissue level, the cell will go for the lactic acidosis and anaerobic metabolism. So lactic acidosis with low ATP energy failure will cause cellular apoptosis. If it's sustained, will go for the organ dysfunction. These reasons, patient will have clinical signs of CNS organ dysfunction like salt sensorium, kidney oliguria or AKI. High lactate we already discussed. The cardiac changes can come because cardiac instability, hemodynamic instability can cause hypotension. If cardiac myocardial decreased oxygen delivered to the myocardium, that leads to the myocardial irritability, can cause arrhythmias. Okay. So there is a, normally we will monitor the oxygen delivered to the tissues by the saturation and pO2. But I already told that patient can have hypoxemia but without hypoxia. Okay. So, but we don't have the alternative to that. The lactate is a very non-specific at the critical ill patient. The multiple reasons can raise the lactate without anaerobic metabolism. So, there is lactate is not a good marker at the fixed cardiac output and the fixed hemoglobin. If any change in the saturation, so it is a serious concern. That is the reason it is a sign of hypoxia. That is the reason we are following we are monitoring a saturation and PO2 in our critically ill patients. Okay. So the third one is a raised serum lactate. We already tell that there is a dysoxia always associated with the raised lactate level because it go for the inability to use the oxygen. So always go for the anaerobic metabolism. The anaerobic metabolism will produce a lactate. Okay. Lactate is very non-specific for dysoxia. Okay. It can occur with other condition also. Decreased lactate clearance, for example, that liver failure can have the high lactate without increased production of lactate. Okay. So there is a classification that why we have to classify the hypoxia, but the treatment also depends upon what type of hypoxia. For example, first hypoxia, atmospheric hypoxia. That means that it is a high altitude. If the patient is high altitude, for example, normal 760 atmospheric pressure, the PO2 will be, atmospheric air PO2 will be 160. If the example, because if a high altitude pressure is 100, what will be the PO2? The 21%, the PO2 will be 21 only. So atmospheric hypoxia, you have to increase the oxygen supply to the patient. Okay, so atmospheric hypoxia need oxygen supplementation. If it is a hypoxia, if it is a problem with the lung. If it is a shunt related, I have to open the alveoli by the deep, or I have to treat the pneumonia, or it may be a VQ mismatch, sometimes will improve with the oxygen itself. So hypoxemia, sometimes hypoxia, sometimes need oxygen, sometimes need PEEP. The third one is an anemic hypoxia. I already told that oxygen delivery depends upon hemoglobin saturation and PO2. If it is anemia also, will decrease the oxygen delivery to the tissues. So I have to correct that. Fourth one is a circulatory hypoperfusion or ischemic hypoxia. So the whatever the, for example, inhaled oxygen is normal, my lung is normal, the oxygen is reached the circulation, but circulation has to, the blood has to go from the lung to the tissues. Then only the oxygen will be delivered. If it is a low cardiac output, even the inhaled oxygen is normal, my lung is normal, oxygen won't reach the tissues. In those conditions, I have to improve the circulation. The fourth one is a toxic or histotoxic hypoxia. This is called dysoxia. The oxygen delivery is normal. Because of the mitochondrial dysfunction, that it causing hypoxia. In this condition, I have to treat the root cause of histotoxic hypoxia. Supportive therapies won't work here. Supplement oxygen or increasing cardiac output won't help in this condition. I already told this is in the type of hypoxia. This type has the worst prognosis. So far we discussed about what is hypoxia, what is hypoxemia, and what is dysoxia. Why the classification of hypoxia is important. Each type of hypoxia have a different treatment. Prognosticatically also very important in this group. It's a toxic and histotoxic hypoxia associated with the worst type. Okay. We all know about that. If you deliver the low oxygen to the tissues, it will harm. What about the higher oxygen delivery to the tissues. So what hypoxia means I'm delivering a supraphysiological oxygen level in a blood or tissues. It's called hyperoxia. Okay. Now, traditionally, it is considered as a safe. A lot of peoples are traditionally started to supply supraoxyl therapy to the patients with stroke and myocardial ischemia. Initially, they thought if it is a myocardial infarction means there is oxygen delivered to the myocardium is low. So if I increase the oxygen in the blood, so it will give some benefit to the myocardium. Like stroke also, the people used to try higher oxygen, routine oxygen supplementation in stroke patients, irrespective of saturation is normal or low. In the post cardiac arrest also, the people used to do supply high. They used to kept after ROS, they used to kept as a higher FiO2. But recent evidence, last few years, it showed that hyperoxia can harm the patient. Okay. So that is a what is the definition of hyperoxia? If PO2 is normal PO2, I already told it's going to be a normal patient who has a room air, who's breathing on a room air, the PO2 will be 80 to 100. Okay. There is no clear cut cutoff. If example, if it's more than 150 is hyperoxia or more than 300 is hyperoxia, there is no clear cut cutoff. If you give the patient having normal saturation, normal PO2, in this patient, if I supplement oxygen, then it is hyperoxia. If example, the saturation is already is 98 to 100 percentage, I'm supplementing oxygen to this patient, definitely it is a hyperoxia. Okay. There is no clear cut cutoff. If any patient is requiring more than the higher oxygen, their saturation already 95. If I supplement that, you can consider it as a hyperoxia. The second thing is that why the hyperoxia is can be harmful. Normally, our body will produce a lot of free radicals. These free radicals will be neutralized by antioxidant. There will be a balance. The free radicals and antioxidant there will be excessive the production of free radicals will be neutralized by the antioxidant, because if there is no neutralization means these free radicals can damage the tissues. Okay, so there is a imbalance. There will be a balance will be there, free radical production and the antioxidant. Whenever higher inflammatory condition like sepsis condition, there will be a lot of free radicals will be produced. In those patients, if I give excessive oxygen, it exaggerates the free radicals level production. There will then in those situations there will be imbalance between the free radicals production and antioxidant. These free radicals can cause organ dysfunction. Okay, these peroxynitrate and hydroxyl, all these will cause oxidative damage to the our vital proteins and lipids and nucleic acids. So it can cause the organ dysfunction. Okay, so if I give excessive oxygen to the any patient, it can increase the free radical levels. It can cause imbalance of the free radical and antioxidant balance. So it can lead to the tissue damage. It is a theoretical explanation. Okay, so studies have showed that there is an animal study showed that oxygen molecules will increase your vasoconstriction. For example, if it is a low oxygen, what that at the peripheries will cause vasodilation to increase the blood flow to the hypoxic tissues. So if we give the excessive oxygen, what will do? It will cause opposite effect. So hypoxia will cause vasodilation. If it is oxygen, will cause vasoconstriction. So oxygen will cause systemic vasoconstriction. The systemic vasoconstriction, what will you do? It can compromise. For example, if I give excessive oxygen, systemic vasoconstriction, it increases systemic vasoconstriction. If the systemic vasoconstriction increases, afterload will increase. So it can decrease your cardiac output. So if it decrease cardiac output, can cause decrease tissue blood flow to the vital organs. So this is oxygen can cause low blood flow to the tissues. Second thing is that normally hypoxic pulmonary vasoconstriction, it is a protective mechanism to maintain a VQ ratio. So if I give oxygen to hypoxic, example COPD patient, the loss of hypoxic vasoconstriction, pulmonary vasoconstriction, will cause something called oxygen-induced hypercapnia. We'll discuss later. The one is that all the regions. For example, if you give excessive oxygen, what it will do? This is SVR. The increased SVR will constrict the cerebral vessels, so it can worsen your brain ischemia. the increased SVR can compromise the coronary perfusion, so it can cause myocardial infarction. So all these oxygen molecules, excessive oxygen can cause increase or SVR. So all vital organ blood supply can compromise. The fourth one is that already discussed, excessive oxygen will produce more free radical. These free radical will cause lipid, all this lipid and protein, all will go, all it can damage all this lipid and protein can cause cellular damage. Other common causes something we call, if you have 100% oxygen, all oxygen will be absorbed from the alveoli later, so it will cause absorption atelectasis can occur. All our supplemental oxygens are dry gases, so it can cause mucosal dry, it can cause mucociliary compromise, so it can cooling of thick secretions, it can cause atelectasis, it can cause bronchospasm, or it can cause infection. All this excessive oxygen will suppress your innate immunity. If you see here, oxygen only benefit to the patient is hypoxia. Hypoxia. Otherwise, if you supplement routine oxygen, it can increase your SPR. This increased SPR can compromise your cardiac output. It can compromise your cerebral blood flow. It can compromise your coronary blood flow. It can produce a more free radical. It can cause a tissue damage. It can cause atelectasis. It can cause compromise of mucociliary clearance. It can cause your immunity suppression. Okay. So these are because of these biological effect in a ARDS patient, it can worsen your ARDS. The CNS already discussed, it can compromise your cerebral perfusion, so it can cause seizure. In the cardiac, it can compromise your coronary blood flow, so it can cause myocardial ischemia or arrhythmia. It can, because of the neutrophil function is compromised by the oxygen, it can cause immune suppression. These are the theoretical explanation. Okay, what is the evidence says? Is there any studies supporting this? All those things. It is excessive oxygen therapy is harming the patient. Based on that, there is a big debate between the conservative or liberal oxygen therapy. Traditionally, in a stroke patient or a myocardial infarction and the post-cardiac arrest patients, they used to go for the liberal oxygen. They want to increase the oxygen delivery to the tissues. Subsequent studies showed mixed results. Some studies showed hyperoxia. There is no benefit of hyperoxia. Some studies show there is an adverse effect with the hyperoxia. First, go with the MI. In this study, actually, whoever's diagnosed as the MI, irrespective of the saturation level, one group of patients received 6 liter oxygen. Other group patients, if they check the saturation, if saturation is more than 90%, they won't supplement the oxygen. One group will receive oxygen. One group, if saturation is more than 90, they won't receive oxygen. Okay, they divided into two groups. This study was published in the NAGM. They measured few things. One is the 1 year mortality and MI rehospitalization. They found there is no difference between that. If the saturation is more than 90, those patients didn't receive oxygen. All other group patients are the saturation is more than 90. Despite of the more than 90, they received oxygen. The outcomes are there is no difference. What they said, in normoxemic patient, that means the MI patient is saturation more than 90, there is no routine supplementation of oxygen does not reduce 1 year mortality or rehospitalization. Supplement oxygen should be reserved for those with less than 90% saturation. Okay. The second group of patients is post-cardiac arrest. This was the meta-analysis, but most of these trials, all these trials are animal trials. They divided into two groups. One group, after the ROSC, they achieve a PO2 more than 300. Other groups, they kept as a normoxia. Okay. So they measured the outcomes are mortality and neurological outcome and histopathology suggestive of oxidative damage. They found all are worst with the hyperoxemia group. So in the animal study, this meta-analysis showed if I kept a PO2 more than 300 after ROSC, it is associated with the worst higher mortality, worst neurological outcome. Histopathological studies also suggestive of hyperoxemia causing more oxidative and tissue damage. But these animal studies subsequent, one more human study was done. It was a very small study. But the study showed that the study didn't prove harmful effect of hyperoxemia, but they said there is no benefit of keeping a higher FiO2 after the cardiac arrest. Okay. So far this MI and the post cardiac arrest status, both the conditions are set. Harmful effects are doubtful. Animal studies showed harmful effect, but the human studies showed there is no harmful effect, but there is no benefit at all. Even the conservative oxygen therapy is as effective as hyperoxemia. Some studies showed hyperoxemia is having harmful effect. There is a These are the non-critical care studies, both myocardial infarction and the post-cardiac arrest. This animal study, these critical care trials, some common ICU rocks, if they ask you in exams, one an ICU rock study is done in a mechanical ventilated patient. They divide in the two groups. The first one is the saturation is they kept as a 91 to 96. If it is other group is a usual care. Okay, that whatever the clinician want to give oxygen, they will supplement the oxygen. Usually, then the study they found most of the patients are received higher than the target level. The most of the patients they kept as a saturation 98 to 100%. They measured as a 90-day mortality as a primary outcome. They found there is a no difference in the mortality. They said the conservative oxygen is safe. Subsequently, their heart ICU study, it also done in a hypoxemic respiratory failure patients. They kept as they previous study, there's a target was SpO2. In this study, the target was they divided into the two groups as a, based on the PO2 level. They kept as a one group as a PO2 of 60, the other group PO2 of 90 millimeter mercury. They also measured 90 days mortality. They found there was no difference. A low PO2 strategy is safe but not superior. The both the studies said there is no benefit of higher oxygen target. The third one is the meta-analysis. It's published in the Lancet. This study is found increased mortality with the liberal oxygen. So, the fourth one is that the fourth study, the hyper 2S study, it was done in the septic shock patient. The one group received 100% oxygen. Other group is FiO2 was titrated to maintain a norm oxygen. In this group is actually stopped very early because there is higher mortality, the trend towards higher mortality with the hyperoxia. That hypoxemic patients and the ventilated patients, this patient didn't show any harmful effect of hyperoxemia. They said the low conservative oxygen therapy is safe. This Lancet meta-analysis and sepsis group patients show harmful effect. Okay. So if you put together everything, some studies showed harmful effect. Some studies showed there is no benefit of hyperoxemia. So one thing is very clear: more oxygen is not always better. Okay, low conservative oxygen therapy is as effective as hyperoxemia. Some subgroup of patient hyperoxemia can harm the patients. Okay. So these things are hypoxemia, hyperoxemia we discussed. Three common mistakes we will do in our critically ICU whenever supplementing oxygen. One is that higher SpO2 target in ICU patient. Second is inappropriate correction of hypoxia and hypoventilation. The third is a oxygen-induced hypercapnia. First, I will tell that we'll go with the why higher SpO2 target in ICU is not recommended. I already told it's not related to hypoxia, hyperoxemia. Hyperoxemia is still it's a controversial area. Some studies showed harmful effects. Some studies showed there is no benefit. Okay, there is no strong evidence suggestive hyperoxemia is harmful. Septic study showed harmful effect, but overall it is a mixed result only. Other reasons we have to keep a saturation. Normally in our ICU, the saturation I used to keep always my saturation SpO2 target should be less than 95. It's not, I'm keeping a saturation of less than 95, not because of hyperoxemia is harmful. Other practical reasons. Okay. If you see here, this is the oxygen dissociation curve. That x-axis showing a partial pressure of oxygen, y-axis showing a oxygen saturation. Okay. If you see here, whenever the PO2 is more than 100, it may be a 200 or 300, 400, 500, 600, or P saturation will be 100 only. Okay. So, if I kept a saturation target of 100 in our ICU, by patients, the patient's PO2 can be 100, it can be a 200, it can be 300 also. If a patient is on oxygen, if my patient is decompensating, some reason respiratory function is worsening, what will happen? If I keep a saturation of 100 SpO2 100%, if patient saturation PO2 is 300, means the PO2 will decrease 300 to 200, then it's to 100, then it's reached to around 80, then the patient will start to desaturation. Okay. So the patient decompensate very late only I can pick whether respiratory decompensation. If I kept a saturation of 95, the PO2 is approximately, it's going to be around 60 to 70. If it is small decompensation, if example my PO2 decrease from 60 to 55, I can see changes in my monitor. See the other group of patient, if example, if I set a 100% saturation, patient on oxygen, the PO2 can be 300. For example, I can pick the decompensation, only the PO2 decrease from 300 to 80. In the second group of patient, if I kept a saturation of 95, even a small decompensation, the respiratory function, I can pick the decompensation. This is the reason I used to keep always my patient saturation irrespective of that. I try to keep my saturation, patient saturation around 95. If the patient is already maintaining 100% on the room air, it's okay. If the patient is was supplementing oxygen, any reason, maybe pulmonary edema or COPD, whatever that, you always try to keep less than 95. In a COPD will go for lower range also, 88 to 92. Okay, this is the reason you should not keep a high SpO2 target in your ICU patient. The second is that inappropriate correction of hypoxia and hypoventilation. If you see here our alveolar gas equation, if you see here, if you apply our atmospheric pressure is 760, the PO2, the normal PCO2, the alveolar oxygen level, partial pressure of alveolar gas will be 100. Okay, normally, if a patient is breathing at the room air. If a patient having, I gave some sedation to the patient, or it may be some other reason, my brain function is compromised, respiratory center is compromised. My patient is, the ventilation is decreased 50%. Previously it was 6 liter, now it decreased to 3 liter. What will happen here? Obviously my PCO2 value will be double. Okay, but what here, my respiratory center is compromised by my inhaled oxygen level is same, my lung function is same only. Okay, but what will happen because of the increased PCO2, alveolar carbon dioxide, my PO2 will be, alveolar PaO2 will be decreased. So the patient will go for saturation. Low patient will desaturate. Okay, normal. Hypoventilation, my lung is normal, my inhaled oxygen percentage is normal. Still, hypoventilation can cause hypoxia because of the increased alveolar CO2 level, not because of the inhaled low inhaled oxygen, or not because of the alveolar gas exchange problem. Okay. So if I supplement oxygen in this group of patient blindly, if some patient is desaturating because of hypoventilation, I'm supplementing some 3 liter of oxygen through the nasal cannula. What will happen here? If you see here, I supplemented 3 liter of oxygen. If I increase my PCO, supplemental FiO2 from 21 to 28%, what my PaO2 here? 100. I corrected my hypoxia, but still my PCO2 is 80%. So always you look for a hypoxia, especially if you think that hypoxia it's related to hypoventilation. Always should not supplement only oxygen. You have to supplement with, you have to improve your ventilation. Otherwise, you have to take ABG and see that what is my PCO2 level, what is your PCO2 level. Otherwise, you simply blindly supplement oxygen, you will miss the CO2 level. Its continuous buildup of CO2 level can be life-threatening also. This is a second common mistake we'll do in our ICU. You have to always, the patient is desaturating, you have to rule out the hypoventilation causes. Okay. Then you can supplement oxygen. All other causes, they won't harm the patient definitely. Okay. The third one is something we call oxygen-induced hypercapnia. We all know that in a COPD patient, you have to keep a saturation of 88 to 92. Why you have to keep a saturation of 88 to 92? Because if I give excessive oxygen to this group of patient, it can worsen my CO2 level. It can cause CO2 retention. Okay, that is the reason. Most of the textbooks are written. The reason for oxygen-induced hypercapnia is if I give the more oxygen, it suppresses my respiratory center. So respiratory, when the minute ventilation level will decrease. That is the reason for the CO2 increase. But if you see here, in this diagram, whenever if I give the x-axis showing a time, y-axis showing the minute ventilation, whenever I supplementing oxygen to the COPD patients, what is happening here? Immediately after my higher supplementing oxygen, my minute ventilation has decreasing. my PO2 is my CO2 also increasing. Okay. So it's suggestive of that if I supplement oxygen, it would suppress my respiratory ventilation. Okay, respiratory stimulation. So it's suppressing the immediate ventilation. After some time, it is this decrease the immediate ventilation is only transient only. After sometimes, if you see here, it started to recovering. The immediate ventilation is started to recovering, but the PCO2 see here it is continuously increasing. Despite of my immediate ventilation is started to recovering after 5 minutes, but still my PCO2 is has to decrease, but it is not continuously increasing trend. So they said there is a some other reason is a predominantly contributing the oxygen-induced hypercapnia. One is the Haldane effect. We all know that if you give oxygen, it will release the carbon dioxide from the hemoglobin. It can increase your CO2. The third one is the VQ mismatch, okay, which is contributing more. That respiratory suppression, it is very minimal only. Okay, the predominantly is contributed by VQ mismatch is contributing 48 percentage. Haldane effect is contributing 30 percentage. Hyperventilation is contributing only 22 percentage. If anybody asks in MCQ or exam, how to tell us is most commonly it's contributed by the VQ mismatch. Second is Haldane effect. Third one is the hyperventilation. Okay. How that oxygen supplementation causing VQ mismatch, which leads to increasing, worsening our hypercapnia. If you take it as an example, this is my minute ventilation is 5 liter. Okay, this is the that is a two compartment model. Okay, that is two compartment. This is a left lung. You take it as a right. This one is a right lung. Okay, the 5 liter minute ventilation. What will that? 2.5 liter will go to the left lung. 2.5 liter will go to the right lung. The blood supply, cardiac output 5 liter, 2.5 liter goes to the left lung. 2.5 liter goes to the right lung. So VQ ratio will be 1. It is a normal one. Okay, when the patient having COPD, what will happen? So one part of the lung of the airway will be narrow. So this part of the alveoli will receive comparatively less ventilation. So here the ventilation is decreased to, before it was 2.5 liter, now it's a zero point 0.5 liter. Because of the hyperventilation, my alveolar oxygen will be low. This low oxygen will stimulate, cause hypoxic vasoconstriction. So the blood supply also will be decreased. See here, the blood supply previously 2.5 liter, the diseased lung part. Now it's a 1.25 liter. Somehow the VQ ratio is 0.5, 0.4. Opposite, the minute ventilation is increased. The ventilation is increased. Now before it is a 2.5 liter, now it's a 4.5 liter, because that 1.2 liter will come diverted to the normal ventilated part. Because of the hypoxemic vasoconstriction, the blood supply also diverted to the normal lung part. So the VQ is trying to bring more towards a normal. This is normal compensatory mechanism whenever in the COPD patient. When I give oxygen, these patients, okay, if I giving some 4 liter of oxygen through the nasal canal, despite of low ventilation in the that diseased part, my alveolar oxygen will be increased now. What will happen? Loss of HOC, hypoxemic vasoconstrictions, are lost at the diseased part. Despite of low ventilation, 0.5 liter, my blood supply is around, it's a 2.5 liter. My VQ ratio is around 0.2. What happened in the opposite side? It's more important. Now the ventilation is still in the normal side is 4.5 liter, but blood supply is, that the blood flow is 2.5 liter. So there is a almost 2 liter going for a wasted ventilation. So that is a dead space ventilation. The VQ ratio is very high. It's more than, it's around 1.8. These reasons, there is a that non-diseased part will go for the supplement oxygen, will cause non-diseased part go for the dead space ventilation. That is the reason. That is that is a predominant cause for oxygen-induced hypercapnia in a COPD patient. So I already told that the previously we thought is a respiratory suppression is the predominant cause. The recent evidence all suggestive of the predominant cause by VQ mismatch. Why the VQ mismatch? I already told, loss of hypoxemic vasoconstriction, hypoxic pulmonary vasoconstriction, loss of hypoxemic vasoconstriction will cause normal, it increase the dead space ventilation in the normal side. That is a predominant cause for oxygen-induced hypercapnia. The second is the Haldane effect. The least common contributor is loss of hypoxic. These reasons, we should not supplement unnecessary oxygen in a COPD patient. Always try to keep a low saturation 88 to 92% to avoid oxygen-induced hypercapnia. The three common mistake: always keep a saturation 95 in a normally routinely in our ICU, because it can, if any small decompensation, we can identify through the monitor. Okay. So second is the avoid blindly supplementing oxygen in hypoxic patient is not recommended. You have to rule out hyperventilation cause. Okay. Otherwise, the continuous buildup of CO2 can be life threatening. Third one is you should not blindly support. You should not get it. You should not give a higher oxygen to the COPD patient. This oxygen will cause oxygen-induced hypercapnia. Just I'm summarizing here. Always try to keep a saturation of 95 to 95, 90 to 95 routinely in our ICU patients. Otherwise, if we are going to do a suctioning, in those situations, you can give a higher oxygen. Sometimes patient went to immediate cardiac arrest. In those situations, you can keep a 100%. Later, you can decrease. If going to ship the patient to some monitor imaging, or going to ship the patient for some procedure, on those situations, you can use a liberal oxygen. Otherwise, always go for a conservative oxygen therapy in our ICU patients, 90 to 95, even the lower range of 80 to 88 to 92. So, like ARDS patient, patient on ECMO, or patient on COPD patient with chronic lung disease. Okay. In routinely other group of patient, always go for a low saturation target. Is anything is 90 to 95 is acceptable. Okay. The second one is avoid hyperoxia, especially subgroup of patient like post cardiac arrest, septic shock, myocardial infarction, or a stroke, because these group of patient, the lot of studies have showed harmful effect also. Okay. The three is a tailor oxygen therapy to individualize the risk profile. Like oxygen-induced hypercapnia, keep in your mind. If you give excessive oxygen, it can compromise. It can cause hypercapnia in COPD patients. The reason is not loss of hypoxia drug. It's the predominant reason is loss of VQ mismatch. Okay. The correction, inappropriate correction of hypoxia and hypoventilation can be harmful. Always look, we have to rule out a hyperventilation cause, then you have to supplement oxygen. You can supplement oxygen, but you have to correct our PCO2 also. So I'm just summarizing. It's a oxygen intervention is very common in critically ill patients. Like any intervention in our ICU, it may be a drug, or it may be any surgical procedure, or it may be a oxygen ventilator. Always avoid unnecessary intervention. One, always that it's like a drug, you have to avoid. For example, you have to avoid hypoxia also, have to avoid hyperoxia. I'm avoiding because of there is no benefit. Some studies show it's harmful effect also. Thank you.
Okay. So thank you, Dr. Vetriselvan. That was an excellent presentation, very sharp and very focused and very evidence-based. Thank you so much.
Thank you,
So, only one question I have for you. What are the cardiovascular effects of hypoxemia, and what are the neurological effects of hypoxemia or hypoxia, whatever you want to call it?
sir. Actually, the excessive oxygen will cause vasoconstriction. Normally these hypoxias will cause normally these hypoxia will cause actually vasodilation. One thing, it's both coronary and the systemic one. So normally, if it is something is called oxygen sensing mechanism, which is called is the adaptive response to the hypoxemia. That is they divide into the two groups. One is the cellular level sensing mechanism. The second is the systemic level sensing mechanism. Whenever that hypoxemia, the systemic adaptive response will activate. The one response will stimulate the peripheral chemoreceptors to increase the ventilation to trying to correct hypoxia. The second mechanism, it can trying to cause vasodilation, increase the perfusion to the hypoxemic regions. The third one is that other cellular level oxygen sensing mechanisms are that produce some hypoxemic inducible factors. These factors will produce angiogenesis, vascular endothelial factors, all will increase. So all these are protective mechanisms. Whenever this product that our hypoxia is these protective mechanisms inadequate, then only it will cause the oxygen tissue injury.
Yeah, okay, great. So just to summarize that, it causes systemic vasodilatation, there's an increase in heart rate, and generally, the cardiac output increases. So
Yes.
the blood pressure does not fall, and that is what happens: tachycardia and maintenance of blood pressure. And also, I will just like to add a few points and ask the audience if anybody wants to answer that. Put it in the chat box. What is the main role of oxygen in the body? Anybody wants to answer that? So the main role of oxygen in the body is to produce ATP. 90% of the oxygen is used in producing ATP, which is the energy currency of the body. First point. Second point is that Dr. Vetriselvan showed very nicely the different PO2 levels in the lungs, in the atmosphere, in the blood, and in the tissues. So in the tissues, kindly be aware that it is. So just close this thing, share screen, Dr. Vetriselvan.
Yes.
So in the tissues, the PO2 is around 20. So one should be aware of this number because it helps to understand the physiology.
Normally, the tissues need continuous oxygen because of the aerobic metabolism. Normal aerobic metabolism will produce 36 to 38 ATP. Anaerobic metabolism only produce 2 ATP and also produce lactate. If it is oxygen is inadequate, what will happen then? If it is produced lactate production, it will cause lactic acidosis. Second thing, this little energy ATP will be energy failure. Both this acidosis and energy failure will leads to cellular apoptosis. If it is sustained, it go for organ dysfunction. That is the reason the patients need continuous adequate oxygen delivery at the tissue level.
Okay. Now, the other thing he showed about hypoventilation,
Yes.
right? Now,
Yes.
there is hypoventilation due to various reasons, and even COPD, the CO2 rises because of hypoventilation, and that is why you get hypoxemia, to be really hitting the crux of why you get hypoxemia and hypercapnia in COPD. It is relative hypoventilation. The respiratory rate is always increased in a COPD patient, but the ventilation is not enough to generate adequate levels of oxygen in the blood and to blow carbon dioxide. But in a pure case of hypoventilation, suppose you give fentanyl and you too much fentanyl and you depress the respiratory system, or there's an overdose of some sedation and you're not giving any oxygen at that time, and the patient just come to you or something, or it's happening in front of you, you're given fentanyl or morphine, and there's a depression of respiration and there's a pure hypoventilation, then there's a relationship between O2 and PCO2. So for every fall of 10 of for every fall of oxygen by 10, PO2 of 10 in the blood, the PCO2 rises by 20. So this is something which helps you at times to find out what is happening. So supposing the oxygen level has gone down to 70, so your PO2 will be going up to something like 80. So this happens sometimes, pure respiratory depression. Another thing is in TBI. In TBI, also the recommendation is only around 96%, 95, 96%, and not beyond that to avoid hyperoxemia. But at the end of the day, different areas in the brain in TBI have different oxygen concentrations, PO2 levels, because of the varying amount of injury, varying amount of blood levels. So in this, because of lack of evidence, we have kept it at around 96, 92 to 96%. But the best way is to measure tissue oxygen levels in the brain. So that is advanced neurocritical monitoring. But there is no evidence to suggest, or we don't have evidence rather to say that we can go higher. There's conflicting reports, and the physiology is that different areas in the brain and tissue brain in traumatic brain injury have different PO2 levels. So that was a few things I wanted to say. And also in a classic acute exacerbation of COPD patient, he talked about VQ mismatching. So VQ mismatching also in classic diseases is distributed in a particular way. So if there is a COPD patient who just comes with exacerbation, a very low level of oxygen supplementation can elevate the PO2 from just like 75 saturation from 75% to 90%. You give 2 liters and the saturation will pick up from 75 to 90%. That is because of the distribution of the units of V by Q. And this is true for many other diseases also, ILD or similar classic diseases of the lung. And if you are actually requiring more oxygen for a COPD patient, then it is likely that the patient has a pneumonia. That is a little a few things I wanted to add from my side. Anything you want to add, Dr. Vetriselvan?
No, sir, that's all. Always I try to keep saturation level in the conservative range because 90 to 95, I already told. If we kept a higher range, we can miss the early decompensation.
Yes, absolutely. And you do not know how much is going. Like you showed, once you're beyond 98%, it can be anything like 100, 150, 200, so it becomes difficult. At 100, if you're keeping 100, you don't know what you're giving. And definitely you
Yes.
showed hyperoxemia, how harmful it can be. Only thing is in traumatic brain injury, there is some dispute because there are areas where the tissue PO2 in the brain is pretty low. So that was all. And any questions from anybody? Okay, Dr. Vetriselvan, shall we close it?
Yes, sir. Thank you, sir. Thank you.
Thank you very much.